So I just did the head, checking for any, I'm checking the frontal, okay? Palpating the frontal lobe, I'm palpating the temporal lobe, I'm palpating the parietal lobe, and I'm palpating the occipital lobe, feeling for any soft spots, depressions, deviations, checking my gloved hands for any sign of blood, okay? Once I'm clear there, I'm gonna go ahead and check here, the periorbital region, okay? Feeling for any soft spots. There's a term that I'll teach you after this because you're going to need to know it. Okay? But this is the periorbital region, assessing the periorbital region for any other signs of decap BTLS. Okay? While I'm here, I'm going to assess his pupillary response. Pearl. Okay? I'm going to test his nose, make sure it's midline. I'm going to visually inspect his nose, looking for any blood or clear fluid coming from his nose. I'm going to check his zygomatic arches for stability. Okay. I'm inspecting his maxilla for integrity. I'm opening his mouth and inspecting for any soft tissue damage, any missing teeth, any possible obstructions. Okay. Now I'm assessing his maxilla, his mandible for integrity. Okay. While I'm here, I'm going to inspect his trachea, make sure it's midline, no deviations. Okay. While I'm here also, I'm going to inspect his jugular veins for any signs of jugular vein distension. Okay. Now I'm going to look at both ears, checking for any clear fluid or bleeding coming from his ears. I'm going to inspect his mastoids, which is that bony prominence behind the ear, checking his mastoids for any bruising, which is known as battle signs, which is an indication of a basilar skull fracture. Okay, I'm checking, did I already say his ears for blood and clear fluid? Blood and clear fluid coming from the ears is another classic sign of basilar skull fracture. The clear fluid is going to be cerebral spinal fluid. Okay, and lastly, I'm going to come down and I'm going to palpate his third, fourth, or his cervical vertebrae, concentrating on the third, fourth, and fifth vertebrae, feeling for any bulges, deviations, or step-offs. Okay, I'm done. That's his head.
Wow.
Yes.
So you're allowed to reach over the patient at that point? Okay.
I'm not stepping over him. Okay. Collar, please. At that point, now I can grab my collar because I went my head to toe and I stopped here. Did not go past the clavicular line yet, right? Until I put a collar on. Now, the one thing in fairness that I didn't mention is that inspection that I just did, that assessment, you're going to be doing that while your partner is holding C-spine. So you're going to have to work around your partner's hands and work with your partner. Okay? I waited for him so you guys can visually see what your standard is supposed to be on what you're supposed to be inspecting. Okay? Now when we go through and practice this head assessment portion, I'm going to tell you what it's hard because right now we're just learning the technique. We haven't learned the theory. Well, shit, Chuck, what's tracheal deviation? I'm going to teach you what I'm assessing the trachea to make sure that it's midline. It's that tracheal deviation is a sign and symptom of potential tension pneumothorax. Jugular vein distension, late sign of tension pneumothorax. Battle signs, it's a late sign of basilar skull fracture. Blood coming from the ears to the nose, late signs of basilar skull fracture. Okay, all these things that we're going to learn stuff, okay? Right now we're looking at technique. Remember, we talked about technique and stuff as well when we palpate the dome. You notice I just wasn't doing this, right? I was squeezing, checking the integrity of the dome. Okay?
Now, when you've actually done this, and like you said, I know we're just learning technique, but if somebody actually in the 3 to 5, can you act like, is it very noticeable?
Oh, yeah.
Or,
depending on the severity of it again. Yeah, very much so, depending on the severity of it. Okay. Any other questions in regards to that?
No.
If
Okay.
like brain is mushy because he got ejected from the car and he landed on his head, do you recognize that he's injured and trauma? So do you just stop or do you just continue even though he's mushy and bloody?
Oh, we're going to keep going. The only thing that we stop and manage is if it has to do with his A, B's, and C's. What's the purpose behind the primary assessment? To find and treat all life-threatening emergencies, right? Rapid head-to-toe secondary assessment, we're just finding out all, because what we consider a life threat is here in the A's, the B's, and the C's. Skull fracture, although it's bad, it'll kill him long term. It's not going to kill him right now. But him not having an airway is going to kill him right now. Him not breathing is going to kill him right now. Him not having a pulse is going to kill him right now. So the only time we stop and fix it is when we have a problem with the A, B, and C. right?
No.
If we have a problem there, so say I come up and I did this. Look, listen, feel for the rise and fall of the chest, feeling for air coming from the nose and mouth, feeling for, and your evaluator says your patient has snoring respiration 6 times a minute. Snoring respirations is 6 times a minute. Is that a life threat?
Yeah.
What does snoring mean? It's a partial airway obstruction. It's your tongue blocking. Is that a life threat? We need to stop it. We need to fix it. Period. Right? And then we move on. Breathing 6 times a minute, is that a life threat? We need to stop and we need to fix it, but we're going to fix the A before the B. You guys will get it here in just a little bit.
Let's say that, what she said is happening and there's a large wound in the head and it's bleeding. While you're doing all this, would you immediately put pressure on the wound or no?
What did I just say, folks?
I understand.
We do not stop and treat individual injuries in a multi-system trauma patient. We put them on the board and we use the board as a full body splint because the goal is to scene size up, general impression, APU scale, ABCs, put the collar on, rapid head to toe trauma assessment, put them on the board, get them in the back, 10 minutes. Rapid head to toe trauma assessment. Okay? We identify it, and then when we get him into the back of the ambulance and we start to transport, oh, hey, by the way, McKenna, you know what? He had an obvious